Thank you everyone for coming. It's another great event for some great topic, a topic that, again, I'm a little biased towards. So we're lucky, very lucky, to have Dr. Martin Voss join us tonight. Very thankful that he's here, not only in one piece, but also just to give us this talk. Just a little bit of background on Dr. Voss. He's currently on staff at the Memorial Sloan Kettering Hospital Cancer Center, in New York City. He's got an expertise and interest in particular with degenerative urinary malignancies, particular focus in kidney cancer. He also does manage to have some interest in bladder cancer as well. But on top of that, Dr. Voss also has an interest in developmental therapeutics or first-in-human trials or phase 1 studies. So certainly a lot of interesting things going on. If you look at the number of studies that he's the leading on from an investigational standpoint, tremendous. But if you look at the number of trials he's actually involved in, also very, very interesting stuff. And with the kind of stuff that's going on in kidney cancer, I think hopefully he'll have a very, very interesting talk for us. I'm sure he will, and we'll learn a lot from it. So, any further delay, Dr. Voss, please.
Thanks, Naveen. Really appreciate it. Thank you, everyone. Thanks for coming out. It's great to be here. I was asked to talk about first-line therapy in advanced kidney cancer, and there are different topics we're going to go through as we go through these slides, and I'm happy to delve in on any one topic that you're more interested in, or fast forward through the ones that are of less interest here. I know we have a good mix here of medical oncologists, radiation oncologists, urologists, so feel free to interrupt at any point with questions and give me some feedback here. You are, of course, familiar with the fact that I have to give you learning objectives before we do a talk. So we're going to go through first-line TKI treatment sort of as one of the focuses this year. Immuno-oncology obviously is an emerging theme across many solid tumor malignancies, and is very big in kidney cancer. So we'll talk a little bit about the clinical trial landscape and what's going on, developing new therapeutics in that domain. And then we'll talk about the risk stratification models that are in place for advanced disease that can help with decision-making, both in the systemic therapy but also for active surveillance and surgical decision-making for some of these patients. We'll have a little bit of data to look at non-clear cell variants, but most of what we'll discuss today pertains to clear cell or conventional RCC, which is not an uncommon malignancy, so very familiar to this audience. It's the third most common GU malignancy that we see. 50 to 60,000 cases are diagnosed in the US annually. I'm not familiar with the Canadian numbers, but one thing that's striking is that out of all the cases that are diagnosed, many of them do not lead to a cancer death, and that's probably explained by what we call the stage migration that's seen in kidney cancer. So over the decades, more and more patients have been diagnosed with earlier stage disease, and it's thanks to our colleagues in urology that these patients are cured, many of them in earlier stages, as their cancers are often picked up incidentally on scans they have for other reasons. For patients with metastatic disease, there's a slew of molecularly targeted agents, and this slide suffered a little bit, I guess, going from one computer to the next. But the point here is that over the last decade specifically, there's been a number of medications with level 1 evidence that led to their approval in this space. And the theme here is that this is this disease that's refractory to cytotoxic chemotherapy and that can be quite sensitive to molecularly targeted agents owing to its disease biology. So back in the late 90s, early 2000s, understanding the fact that in clear cell kidney cancer, functional loss of the von Hippel-Lindau protein, activation of HIF signaling, and angiogenesis around the tumors sort of drives this disease, led to the development of several treatments. And similarly, upregulation of the mTOR pathway in this disease was exploited in the development of mTOR inhibitors here. More recently, and you see this is a little bit shifted, but as of last year in the United States, we had approval for the first targeted immunotherapeutic, nivolumab, and there's many other medications that are in the pipeline now. So the first thing I wanted to talk about before we actually go into the data for how to treat systemically is how do we understand how patients differ with metastatic disease? One thing that's actually unique to kidney cancer compared to other solid tumor malignancies is that there's a huge breadth, as you all know, of how this disease can behave. And there are patients with metastatic disease that we actually have on active surveillance, sometimes for years without requiring any systemic therapy, and others just blow through a couple of agents before they succumb to their disease in just a few months. And there are some strata that are in place that help us understand, and this again is data for metastatic disease. The traditional model for this is the MSKCC, or the Memorial Sloan Kettering Cancer Center risk stratification that was originally developed in the early 2000s, and that was before we had these medications approved. So this was data that was generated in interferon-treated patients. That was the standard of care at the time. So patients that went on a number of clinical trials with interferon were retrospectively analyzed in multivariate analyses, looked at various clinical and laboratory strata that could estimate how high a risk a patient was versus how indolent disease was. And these risk factors can then be added up to a score, and patients can be categorized to favorable, intermediate, and poor risk. And you can see here that the overall survival differs significantly. And while this was originally developed in interferon therapy, it's been validated over and over again and is still used as the most common stratification tool for design of clinical trials. So if you want to balance two arms on a clinical trial that you randomize patients to, and you want to make sure that you don't have all the bad players in one arm and the others, then oftentimes they're stratified by this. I'm often asked at sessions like this, what do you make of this Sloan Kettering risk strata, or how do you use it in your practice? I actually use it very little in my practice outside of clinical trials. There are some unique situations that we'll talk about where it can be quite helpful, but in choosing my systemic therapies, this is not a tool that we use day to day. This is very helpful for clinical trial design, and it can be helpful in making some decisions that we'll go through. The more recent data has actually been spearheaded by an investigator here in Canada. So Danny Heng from Calgary leads efforts for the International Metastatic Database Consortium, the IMDC, which is an international database that has pooled by now thousands of patients from all over the globe with metastatic disease, and can retrospectively query these to ask very similar questions. So this is all now patients treated in the era of targeted therapy, and to me this is probably the most accurate way to risk stratify patients in 2016. And you can see it's a very similar model, and you can see now this is sort of the landscape of kidney cancer in the real world. So this is real world data. This is not necessarily all taken from clinical trials, and you can see that patients with favorable factors here, I don't know how to operate the laser pointer, well, I'll just point to it, have a median overall survival in the range of 40 months, versus patients with poor risk disease really have quite an aggressive course. One of the scenarios where we can actually make use of these strata and understanding the biology or sort of the trajectory of the cancer better is when we think about the fact that not every patient has to start systemic therapy right away. And that's a concept that's difficult for many patients to understand. It's also difficult for many referring doctors to understand, but there are patients that don't have to be started on non-curative therapy. So remember, these systemic agents don't make the cancer go away, and they can produce side effects. So some patients are actually better off delaying the initiation of such treatment. And there's phase 2 data that was published earlier this year. And this is a publication by Brian Rinne from Lancet Oncology this year. And there were a couple of centers that participated in this and treated about 50 patients, or didn't treat them. They watched them actively. And these were all patients that in order to participate in this trial had to have metastatic disease, and they had to be asymptomatic. So if they had no symptoms from their cancer and their doctors were considering them for active surveillance, they were enrolled on this trial to watch them prospectively. And you can see here on the left that again there's a breadth of how long patients will stay on active surveillance until they have, and that's the blue point on each of the individual patient bars, until they have RECIST progression, meaning a scan that shows significant growth of their cancer. And you see here that there are some patients that are 70 months plus out and have never started systemic therapy. And if the investigators now went back and queried that data and tried to find out which are these patients and how can they be identified beforehand, and that's where the IMDC risk strata that we just looked at came in handy. So patients with a low IMDC risk and very few organs involved with metastatic disease fared better with a median active surveillance time of almost 2 years versus patients that had any other setup in terms of their risk factors and their disease distribution. So this is probably the best prospective data that we have currently to guide decision making in that sense. And what I do in my practice is if I have patients who are asymptomatic and they have low volume disease, say they have sub-centimeter pulmonary metastases, even if I'm convinced that it's positive, or sometimes they have a 1.2 centimeter that was biopsied and is positive, I do watch them, and patients get very comfortable with this. They're very nervous as you start the process, but then very quickly they start to ask you to space out the CAT scans and don't see them so frequently. Any questions about active surveillance in this thing? So essentially these are all individual patients, and the length of the bar indicates how long they've been on a surveillance, and the blue dot is at what point they first had RECIST progression on a CAT scan. So you can see that some of these came off, but others, the investigators chose to leave them on active surveillance. RECIST progression criteria are pretty arbitrary. I mean, they don't necessarily have to guide our treatment decisions outside of clinical trials. This trial was written so that patients could be kept on active surveillance if deemed safe by the principal investigator and the treating physician beyond progression. You can see some interesting examples here. This patient who progressed quite early and many months afterwards is still on active surveillance.
Are these papillary clear cell? Or?
These were clear cell kidney cancer patients, and that's important. So understanding the disease biology, just like the risk strata, the IMDC criteria, the MSKCC criteria, disease biology, histology, and the different subtypes goes into that. So a patient with a high-grade papillary kidney cancer is not going to fare well in active surveillance, and someone with a low-grade chromophobe kidney cancer actually may. So, but most of the data that we have, and a lot of the experience and the comfort that one has, and this is clear cell because that's most of what we see. It's 75 to 80% of our patients.
So in this phase 2 study, was there any indication that these patients are the same as other patients who are treated?
Yeah, there's a lot of subgroup analyses that were done looking into how they were affected by their cancer. So no one became symptomatic on this disease. They all were taken off trial before they developed symptoms. There are 2 patients in the cohort of 48 that developed brain metastases on surveillance. That's sort of one of the feared complications of what can happen. Beyond that, there was no one on the trial who could not go on to systemic therapy afterwards. Everyone who ultimately was taken off went on first-line therapy.
So in your day-to-day practice of doing this, do you go by resist progression, or do you?
I don't. No, I don't do calculations. Yeah, so that's a good question. So what should trigger one to stop active surveillance and consider initiation? So what I tell patients before, and because patients ask me that question also, I tell them if we see disease occur in a new organ, that to me just signifies that there's some increase. If the pace of disease increases significantly, so if you go from scan to scan and you've always seen, 3 millimeter increase, 3.5 millimeter increase, and all of a sudden, there's an area that doubles in size. And certainly, if they're symptomatic in any way, then I usually get them started as quickly as possible. Okay. Cytoreductive nephrectomy. So we do have urologists in the audience. I only have a few slides on this, but it's obviously a big topic, and people have very strong opinions on the matter. Be curious to see what people here have to say. Right. So for all that are not familiar with the term, many patients develop their metastatic disease as a recurrence after they've undergone nephrectomies previously. But patients that are diagnosed off the bat with stage 4 disease, say a patient that walks in and has a primary tumor, but at the time already has pulmonary metastases, hepatic metastases, can be considered for cytoreduction, meaning it's not a nephrectomy that is performed in curative intent. And the question then, and patients ask that all the time, what's the point in it? If we take it out, but the cancer is still there and it's still not cured, why should it be done? And the motivation to consider it dates back to the cytokine era. So this is pooled data from 2 large randomized clinical trials that were done at the time of interferon. This was the SWOG study and the EORTC trial, and there was a joint analysis that was published subsequently. And essentially, those were prospective randomized studies where patients were randomized to either go straight on to interferon therapy or they underwent a cytoreductive nephrectomy before starting systemic therapy for their metastatic disease. So everyone here was diagnosed with stage 4 disease. And these trials both showed an overall survival benefit. to cytoreduction. Obviously, a highly select patient population. You don't choose a patient that's huffing and puffing with pulmonary metastases, and you wouldn't choose someone with an unfavorable Charlson index. But in patients that are deemed surgical candidates, there was a suggestion at the time that it added to cytokines alone. Now, what we don't know is whether that still applies. So a lot of doctors that are critical towards cytoreduction say, well, maybe the systemic agents that we have in 2016 are so good that we don't add to that by taking out the primary tumor. And sometimes the decision making is much easier if you have a patient who's very symptomatic from their tumor, or they have gross hematuria and they have very little disease elsewhere, then there's palliation also in doing the cytoreduction. But if patients are asymptomatic from the tumor, then really it comes down to, is there a benefit in terms of outcome? Now, for targeted area, we have retrospective data, and there's this number of series that have been shown. This is the data that I like best, and it's again the IMDC and Danny Hang who published this, and I apologize for the slides being jumbled down here, but essentially what was done here is this is a cohort of over 1,500 patients that were matched in that half of them had undergone a cytoreductive nephrectomy, so they had a nephrectomy at the time that they were diagnosed with metastatic disease, and the other half did not. And they were compared in terms of the outcome. Now, you would say, but just looking at the entire cohort, that this must be very biased, because obviously all the patients that look well, feel well, are younger, are going to be the ones that undergo surgery, and the ones that are elderly or that are frail, symptomatic from the disease might not. But one thing that the IMDC did in their analysis, they said, well, if that's the case, then why don't we look in paired analyses throughout the different IMDC risk strata? So looking at this now and looking through risk factors, patients who have 0, 1, 2, 3, 4, 5, or 6 of the risk factors, meaning the indolent disease and the aggressive disease, then how do these outcomes compare? And what they found was what you would expect by common sense. If you have more aggressive cancer, then you should better get moving with the systemic therapy. If you have less aggressive cancer, then you benefit. So you see here highlighted in green the first 3 rows, patients with up to 3 risk factors in their comparison on log rank analysis had a significant improvement with cytoreductive nephrectomy versus no surgery. But once you get into the higher risk patients with more aggressive disease, you lose that OS benefit. Now, the shortcoming of this analysis is obviously it doesn't integrate comorbidities and how good a surgical candidate a patient is. So it could still be that the patients with surgery were just the healthier appearing patients outside of IMDC risk strata. Ultimately, the only way to find out is, again, to look at this prospectively. So this is a study that's going on in Europe presently. That's the Carmina trial. It's a phase 3 study of over 500 patients that are being randomized to either go straight on to sunitinib for metastatic disease or to have surgery done before they started. And per all the trials I'm going to show you today, I have the estimated completion date, not because someone slipped me a piece of paper under the table, but because it's listed on clinicaltrials.gov with all the limitations of that. So it's estimated to read out in 2 years. There's a second trial that's going on through the EORTC in Europe, and that is a sequenced study of doing nephrectomies, cytoreductive before sunitinib, versus doing the opposite, saying, well, maybe we should give them a little bit of sunitinib. It might facilitate the surgery. And there are a lot of people who say that it could serve as what we call a litmus test. So if you have someone and you're not so sure how their cancer is going to behave and you don't really trust the IMDC score, well, maybe it's nice to put them on systemic therapy for a couple of weeks, because if they quickly get worse, then you're going to know it. The cancer might show its face. Any questions? I'd be curious to hear what thoughts anyone has on the topic of cytoreduction. Is that a common practice here? Do you use IMDC risk strata?
More common in the last 2 months.
And how so? What happened over the last 2 months?
I retired.
Okay, good. Explain.
So I agree with your first slide, or with regard to the cytoreductive nephrectomy and TKIs, that we just don't have to do it.
Mm-hmm.
And my other argument is the interferon data is really, in retrospect, a poor study. It didn't meet its accrual, and so they tried to combine them. One was, I don't know, 50 patients, and they needed 200 or whatever.
Yeah, it's underpowered.
The American study had took 10 years to accrue. They were supposed to accrue in 3 or 4 years, and so that affects their reliability of the data. And the cytorectomy arm was favored the good performance status. He said it wasn't significant, but there was a bigger group of good performance status 0. And also they had a lower grade tumor which biased towards the refractory. So it's really unfortunate. I mean,
Yeah.
but the biggest thing is it's not the same. They're on the nowhere near what they are. So how we can just keep going back to that and put on the
Because it's the only prospective data that there's been. But Naveen, yeah.
So I'll say a few things. I mean, I agree with you, we do, the data is not the best, but it is the best we have. And as well, I mean, I have seen this, and I mean, maybe you have too, patients who have very low burden of disease in their lungs and a large tumor primary, you actually take it out, and for whatever reason, those lung lesions disappear miraculously. No intervention, no treatment whatsoever. There's obviously things that we don't understand that are going on. Why these lesions suddenly disappear is related to the immune system. There's something about a large primary that was driving or able to evade the immune system. And now with it gone, the immune system suddenly robust and we can attack and clear these rogue lesions. But again, that's by far the exception more than the rule. Again, I think it's a question we need to answer. Unfortunately, I don't know if certain time's still open. In fact, I think they may close.
Yeah, I think it's on hold. So again, this is very similar to the interferon experience. Carmina was supposed to have been completed by now also. So it's just these are very slow to accrue. And you can imagine that it's difficult for patients to sign up for a randomized trial like that. It's one thing to sign up to 2 different systemic agents, but to have such drastic differences in management is just difficult. I mean, in my own practice, it's often easier if there's something that you feel you're going to improve with the surgery. If the patient, be it that they have hematuria, be it that they have pain, or paraneoplastic syndromes. Sometimes I saw a patient, recently who had polycythemia, and she was hypercalcemic, but she had very small metastatic disease. So it was very, suspicious to me that most likely the primary tumor was driving things, and that patient underwent a nephrectomy and all her labs improved afterwards. And we see that often, so that's interesting for the residents. In non-metastatic disease, you will see a lot of laboratory abnormalities. You can see what we call Stauffer syndrome, which is LFT abnormalities. Everyone is curious if the patient has hepatic metastases. There's nothing. You take out the kidney, and the LFTs return to normal. There's hypercalcemia, anemia, polycythemia. So there's a lot of things, but it's tricky to make these decisions in a patient who's got no symptoms from their primary, and you wonder if you should just get started with systemic therapy. Right. Yeah.
I think everybody agrees that it's highly important.
Right.
And the conversation's very different. I think it's going to be a laparoscopic set of reductions, which they both
Yeah.
often the conversation is steered by what the surgeons think they can do.
Right. Good. Okay.
This is one of the most difficult decisions, I'm sorry, that we face, is because as you're alluding, you don't have the data to support the decision making. And I think a lot of what guides you is performance status and clinical disease. It's a tough decision. Open versus lap, you're looking at a couple of weeks.
Well, that's often, but I've had that conversation go though. I don't want to do it because they go from procedure.
Yeah, but it's still a big operation on the inside. You're still going to have, you're really looking at it.
No, I agree.
Usually it's open because it's the other group is the Thomas group. That may be asymptomatic, low burden of disease in the lungs, and they know they're going to get into trouble. It's everyone I struggle with, and as you can tell, I struggle.
And then controlling the high level of laparoscopic surgery when you have lymph node mass is very difficult.
So I'm curious to hear for the stage 3 patients, so node positive patients on imaging, is there a template that you followed for your nodal dissections, or is it you go in and you see what's there and you take out suspicious lymph nodes? Is there like a classic template that you resect for all patients that have nephrectomies done, not the cytoreductive nephrectomy, say in stage 3 disease, stage 2 disease?
So the data on that's still out, right? So whether or not you have to be like the Mayo Clinic and clean out everything, so the intra-aortic cable and periaortic and paracable and intra-aortic cable lymph nodes. That Rodney Grew, I think, was looking at, who was when he was at the Mayo Clinic. That data isn't there. So you know, you take out the lymph nodes and that are enlarged, and half the time that are enlarged aren't involved with cancer.
Yeah.
And that's part of the problem. So what do you card? And you take out the abnormal ones, and we don't really follow it per se, but we try to get the intra-aortic cable ones as well, because they also have a high percentage of being involved.
Yeah. Okay. Okay, so let's talk about systemic therapy. So once you jump the gun and you start, be it before or after the surgery, what are standards in the first-line setting? So, you know, there are various guidelines that you can follow. The most commonly used in the US is the NCCN, so the National Comprehensive Cancer Network, which lists a number of options. And one thing that's interesting, actually, to point out is this is now their recommendation for 2016, and one of the first things that pops up on the list is clinical trials, even in the first-line setting with so many drugs that we have approved. And the reason that that was added by the NCCN committee is because, you know, there's a lot of interest and a lot of promise in the data that we see emerging now in combination therapy that we'll touch upon later. The way that the NCCN does this is they categorize their recommendations. So any one recommendation that is a category 1 evidence means that there's high level of evidence and that everyone in the committee agreed that this is recommendable as an option. And the category 1 options in the first-line setting are sunitinib and pazopanib as the tyrosine kinase inhibitors, Avastin plus interferon, which is not used much in the United States because of the downsides of giving interferon to patients, and then temsirolimus I put in parentheses because it's recommended for poor-risk patients only, and we'll look at that briefly. So really, the standard of care for the majority of patients that start systemic therapy in 2016 are tyrosine kinase inhibitors, so small molecules that are administered orally and that primarily block blood vessel growth, so they're angiogenesis inhibitors that block the VEGF receptor too. And the two drugs that are most commonly used because they have level 1 evidence in the first-line setting are sunitinib and pazopanib. And here are the registration trials, just summarized very briefly for both of these. So the sunitinib trial was in the New England Journal of Medicine almost 10 years ago, and it put an end to the interferon era in that it beat interferon in progression-free survival in a 1-to-1 randomized study. Pazopanib came a little bit later and is a very similar molecule that is made by a different company. This was a placebo-controlled trial that was conducted in cytokine pretreated and treatment-naive patients, and you see the primary efficacy analyses here. And when you look at the number, not that we ever compare across trials, we do it all the time. These are both of the registration trials, and you can see the median progression-free survival, the median OS, and the response rates are in very similar ranges here, with a median control rate of somewhere just short of a year for these drugs. This is real-world data looking at this, again from the IMDC, looking at a large number of patients. You can see here over 3,000 sunitinib-treated patients and over 300 pazopanib-treated patients. So that gives you a reflection internationally, what over time has been the preference, and that is because sunitinib was marketed much earlier than Votrient, and that especially outside of the US, many countries had that as their one option available for the longest period of time. But you see that the outcome, this is OS data, is very similar for both drugs, and the same applies to objective responses in this database. The question then is, how do you choose between the two? And that's something that medical oncologists sweat over, and there's podium discussions up the wazoo about Votrient versus Sutent. And ultimately, this led to a randomized trial. The COMPARE study at its time was the largest study ever conducted in clear cell kidney cancer, over 1,000 patients internationally were randomized to receive one of the two drugs. And this was set up as a trial that was conducted by the makers of pazopanib with aim to show that pazopanib was non-inferior to sunitinib. So they were both on the market already, but they wanted to prove to prescribers that there was no shortcoming in using pazopanib over sunitinib. And this is the primary endpoint, PFS non-inferiority, and this was a positive trial in that it was found to be non-inferior, meaning there's no difference in progression-free survival that was reported on this study. And there are secondary analyses for objective response and overall survival that bottom line also say that these are comparable agents on this study in terms of what was found for the effectiveness. Now, the makers of pazopanib in this study obviously were hoping to find convincing evidence that there was a reason to choose their drug over the other, and there was a sense that many physicians had that Votrient was easier tolerable for patients. So this trial had a long list of quality of life and toxicity checks built in, and you can see here AEs that were affecting more than 30% of patients listed for pazopanib on the left and sunitinib on the right, and highlighted in blue are the ones that were significantly more frequent for sutent, and in yellow the ones that were significantly more frequent for pazopanib. And the clinical toxicities that we often find dose limiting, almost all of them seem to be higher in incidence for the sunitinib arm. So that includes fatigue, hand-foot syndrome, stomatitis, taste changes. In the laboratory assessments, pazopanib definitely, and anyone who gives a lot of it will attest to that, can cause more LFT abnormalities. Both drugs can do it, but a lot of the cytopenias seem to be more frequent for patients treated with sunitinib. This is the quality of life data, and as a reminder, this is not what the trial was powered for. These are secondary analyses, but there was a slew of questionnaires that patients had to fill out on those trials. These big booklets that they had to fill out throughout the first 6 months to test across a total of 14 quality of life domains. And 11 out of the 4 seemed to show more favorable findings for Votrient. So for pazopanib, you can see here that there was significantly less fatigue on these quality of life scores, and for hand-foot syndrome, there seemed to be less soreness in the feet. And this is how patients perceive this. Now, the limitations to these quality of life assessments are that they're not standardized assessments, that not everyone speaks the same language. How do we grade these? How do we interpret it? But the sense was, looking at this data, that there was better tolerance for one agent than for the other. Critics of the study will say that the quality of life assessments and the tox assessments were all taken at the 4-week mark, and anyone who gives sunitinib knows that we typically, or at least by label, give it for 4 weeks before patients get a 2-week break. So proponents of sunitinib will say it's unfair to test, and that's obviously not a trial that was written by the makers of sunitinib, to test exactly at 4 weeks and see how the foot soreness was, and might it have been very different a week later. Patients might tell you that that doesn't matter because they still felt crummy after 4 weeks. And this is another data point that was included in the trial, use of medical resources. So how often did patients call the office? How often did they go to the emergency room and so forth? Which also tracked with the quality of life data, and that at least for the first 2 categories, there seemed to be more activity in sunitinib-treated patients. This is obviously a difficult thing for us to assess. This is data from the famous study. It was an observation trial that was done in Germany and published recently, looking at how patients versus doctors perceive patients' toxicities. And this is in kidney cancer patients treated with TKI. And the bottom line here is that we underestimate how our patients feel, and oftentimes the degree of toxicities they report. Yeah, that's right, those patients. What are they doing? Yeah. Let's say there's a discrepancy between the two. So that brings us to the Pisces trial, which is a study that was done in Europe and is very interesting in its design. So this was a trial where patients were randomized and blinded, and it was a double-blind design, so the doctors also didn't know which the patients were on first. And they would get one of the 2 drugs for the first 10 weeks, and they took a 2-week break, and then they flipped to the other drug. And after this was all done and over, the patients were asked, and that was the primary endpoint for which the study was powered, what was your preferred drug, drug A or drug B? What did you like better? And that was it, just flat out. They were asked that question. And this is the data that came out. So patients that were blinded to their treatment preferred pazopanib in the majority of cases. There were some patients who did prefer being on sunitinib. But it seemed to be slanted towards one of the two drugs. The doctors who were also blinded were asked, and you can see in light blue the doctors and in dark blue the patients. And again, patients seem to like the one drug better, and doctors seem to concur, which probably tracks with how the patients were feeling at the time or how difficult it was, to manage them then. Again, there's numbers of limitations to that study, right? It's a cool design. It's very interesting, but this was an intention to treat analysis, and actually only 2/3 of the patients that went on the trial entered the analysis. So it's not clear that this trial wasn't also underpowered. And again, the timing of the primary endpoint assessment was at the end of week 4, which is at the height of sunitinib toxicities. There were some discrepancies in AE reporting. Does everyone agree on what fatigue is and how to score it and so forth? But these two studies together sort of gave the same sense, and they came out around the same time and were conducted by independent groups of investigators. Any questions about these comparative studies?
So I have one quick question.
Yeah.
So most of these tyrosine kinase inhibitors are pan-tyrosine kinase inhibitors. Sorafenib is probably even more so. And as we try to get more specific, the patients may tolerate it if the vascular event.
Right.
But in our Canadian data, there was a guy by the name of George Bjornson that said you have to dose these people to toxicity to have a response. And I'm just wondering your take on that and the data you're presenting, patient tolerance, physician-perceived tolerance. In our animal models, if we give combination therapy to the animal really sick, we can actually control their cancer, so they don't spread around when they're on combination therapy.
There's actually a couple of interesting questions. So, first things about toxicity and how it correlates with outcomes. So there's a lot of investigators that feel, versus some patients who have toxicities, we are underdosing a lot of patients with the medications. One thing that's important to know, all of these medications that we have are started at a flat dose. Doesn't matter if your patient is, a 100-kilogram, construction worker, or if it's an 80-year-old little old lady per label, both of them will start at the same dose of the medication. And there's something wrong about that. Why is it that we get drug levels for cyclosporins, and we can't do it for our cancer medications? But that's how these medications are, on the market. Now, the one medication that's an exception to that is axitinib, or Inlyta, which is not in this talk because it's a second-line drug. But when Inlyta was developed, the investigators that wrote the trial with the company said, well, there's something wrong about that concept. And they wrote it so that patients who were void of any toxicities were dose escalated. So all other trials only have dose de-escalation for these drugs. But on that trial, if patients were to have no hypertension, no grade 2 toxicities of other kinds, they went from 5 to 7 to 10 milligrams. And that's how the drug is actually labeled. It's the only drug that is labeled to dose increase and dose intensify up until you develop side effects. There was a randomized trial that followed that study then to look into whether that had an effect. So patients went on that medication, and if they had stable disease on the first scan, they were blinded and randomized to either be dose escalated with a placebo, so not really dose escalated at all, or dose escalated for real. And then there was the primary endpoint of the trial was looking only at that stable disease randomized population. And the likelihood of developing an objective response was significantly higher for the patients that were dose escalated. So that gave proof to your point that you brought up before. Some patients actually need more drug, not less drug. That drug, axitinib, and that goes to your second question, is the most narrow tyrosine kinase inhibitor that we have. And we see less liver function test abnormalities, and we see quite a bit of GI toxicity, and definitely a lot of hypertension, which is mediated by VEGFR2. But there are a lot of people who think if you have a broader kinome, you're just going to hit more targets and you're going to get more collateral damage, so to say. On the flip side, that might be a good thing. The latest approval in the TKI spectrum as monotherapy is cabozantinib, which is a drug that's actually quite potent for 3 relevant targets, VEGF, AXL, and a protein called MET. They all have been implicated in angiogenesis, and that drug is one where it's been shown that even patients who are heavily pretreated with serial TKIs, if they go on that TKI, then they can still achieve response, and that's probably because we're hitting so many new targets with it. So there's always this back and forth about, is it better to be narrow, is it better to be broad? But there is something about dose escalation. I know that there are a lot of proponents also for sunitinib and even pazopanib to to work hard to keep patients on high doses of drug. One way to do that is actually sort of the next set of slides. So sunitinib being one of the most commonly used drugs in this disease and one of the first medications to be approved has obviously been through the ringers. I mean, people have tried all kinds of stuff in order to make this medication more effective and more tolerable. So as a reminder, again, the original trials and the original label are to give this medication at 50 milligrams 4 weeks, followed by a 2-week break so that side effects subside. And the schedule that has emerged to be promising both in effectiveness and tolerance is 2-week, 1 week instead of 4-week, 2-week. And this is, we don't have to go through all this, but the key points actually all sort of tell the same story. These are all small retrospective series from around the world that look at patients who start at 4-week, 2-week, and then sequence over to 2-week, 1 week because they had toxicity, or patients that did that from the get-go. And there tends to be a lower incidence of dose interruptions, so better dose exposure, lower incidence of toxicity, and for some trials, even better effectiveness, which probably is a testament to the patients being on drug more consistently. And I'm not going to go through all of these. I'm just going to point out that there's actually one prospective trial that has been presented last year at GeoASCO. There's a phase 2 randomized study of over 70 patients conducted in Korea, and they went from the get-go either on the old or the new schedule, and there was better outcome on that trial with the new schedule. And that's probably because patients were having an easier time staying on drug and ultimately got better dose exposure. I know that Naveen and his colleague here have been very invested in exploring different sunitinib schedules. I'd be very curious to hear you comment on this data also and just give us your take on that.
Yeah, we've talked about this within the group, but just the whole idea of individualizing therapy. We recently looked at our Canadian data through that Canadian Kidney Cancer Information System, so Canada-wide database, looking at pazopanib versus sunitinib, and again, keeping in mind that we do tend to select perhaps for patients who may be more fragile and maybe more have more comorbidities for pazopanib. But if you just look at the sunitinib versus pazopanib data, sunitinib did fare better than pazopanib. But it was pretty impressive. It was an 11-month difference. And if you look at the IMDC data that you had up before from Dr. Luis Morales working with Danny, there's equivalence between sunitinib and pazopanib, but I think a large part of that data is looking at patients who are on that standard 4-2 schedule. If you break down our data and you look at those that were dose individualized or who may have had a different schedule, you are seeing clearly a better outcome compared to those that were on the standard dosing. And so there certainly is something there. And again, the commentary here, and I said this earlier, is it's not that sunitinib is better than pazopanib. I think it's just that we're used sunitinib better than maybe pazopanib, that we are maybe maximizing its utility by having these schedule alterations to make the drug more tolerable, to allow patients to be on treatment that is acting against their cancer for longer periods of time.
Yeah, the question that comes up then also is a patient who's being dose optimized in a schedule like that being treated by someone who is just more aggressive in treatment or maybe also more experienced in how they use the medication, someone who's on standard 4-2 versus someone who's being individualized, might actually be treated altogether different. So it's difficult to interpret that data, but if you ask RCC investigators, anywhere you go, everyone is now exploring these schedules in their own practice in one way or another. I'm just going to touch very briefly upon mTOR inhibitors. There's an mTOR inhibitor called temsirolimus that is FDA approved in the frontline setting, only for poor risk patients, and that's because that's how the trial was conducted. So that was a clever move on the company's part at the time. They were the only ones to focus on that population specifically. They compared interferon with temsirolimus with a combination of both, which got lost here. And they found that there was an overall survival benefit for the investigational arm compared to interferon. This is a drug that's given intravenously on a weekly schedule. It's very intense for patients to keep that schedule. And one thing that I always point out is everyone asks me, well, should all the poor risk patients now be treated with temsirolimus? We actually don't use a lot of it. It's rough on patients to do that. There is good data for poor risk disease for the TKI. Just because the TKI trials did not exclusively focus on poor risk disease doesn't mean that these agents don't work in poor risk disease. This is again from comparison. You can see here, comparable outcomes if you compare to the slide before with the tyrosine kinase inhibitors in that space. One thing that I'm asked all the time is, what is it with biomarkers in this disease? And it's almost counterintuitive that this is the one solid tumor malignancy that has had molecularly targeted agents as its standard for the longest time, but has no predictive biomarkers that we use to select our agents. And oftentimes the question has come up whether it helps to choose between a mTOR inhibitor or a VEGF inhibitor, especially if you go into the second line space. This is data that we published 2 years ago, taking what we call an outlier approach. So we looked at a group of patients, 6 of which had extremely favorable outcomes with mTOR inhibitor therapy. So 27 months, 34 months, this patient 3 years on therapy. And we took their tumors and we tried to find out, is there anything in the mTOR pathway that says why is it that their tumors responded so well? And for the majority of these, we actually found something. So we found alterations in TSC1, which is a negative regulator of mTOR. We found gain of function mutations in the mTOR protein itself. And we didn't find any such thing in patients that had blown through mTOR inhibitor therapy. So when we did this originally, that was sort of the hope that we were going to find a predictive biomarker for this disease. And it was even more interesting looking at individual patients. So this is a patient where we sequenced different areas within the tumor. And we found that in the same tumor, some of the regions had a mutation in mTOR, and other regions had a mutation in TSC1. So something about the biology of this cancer sort of, as it evolves, seems to push the tumor evolution towards the PI3 kinase pathway. And this patient was a setup for everolimus therapy and was on treatment for an extensive period of time. We then went on to test that hypothesis on a prospective trial. So this is a RECORD-3 study, which in frontline, a phase 2 trial, compared everolimus to sunitinib. So we had now a randomized data set, and we analyzed tumors from over 300 patients in that data set and tried to see, were we right about this theory? Would it be that patients with alterations in the PI3 kinase pathway would fare better with everolimus versus sunitinib? Now, this trial was a negative trial. It did not show that everolimus was comparable. So in the first line setting, sunitinib was clearly the better drug. And when we looked at this by molecular strata, you can see here the core PI3 kinase pathway mutation. So anything that was activating the pathway, at least on paper, we think should have pushed our results towards a favorable outcome across the trial with everolimus, and that was not seen. You can see here all of these patients tended to do better with TKI therapy in the first line setting. So this did not confirm the outlier data we have. And the way I interpret this is there are absolutely these rare patients out there that have these tremendous responses with this class of agents. And if that happens, then there's probably something you can find in the tumor. But on the flip side, not everyone who has an mTOR mutation is going to do so well in it, probably because they have other genomic events, or the mTOR mutation was lost as the tumor evolved further. But nothing that helps us guide decision making the way that a V600E BRAF mutation helps in melanoma, or a KRAS mutation may help in colon cancer.
So Martin, the question then, do you think it's the tyrosine kinase multiple pathways in survival as opposed to mTOR inhibitors that are more specific to the mTOR pathway?
Right.
And then, I mean, in mTOR inhibitors, the autophagy pathway is really controlled by that. And how can you sort of, a tumor that's trying to survive, it's got all its survival pathways upregulated, dosing to off-target effects of TKIs or non-TKI effect that would likely be more beneficial, right?
Yeah, you would think so. I think the one thing that's driving a lot of this, and this tremendous benefit that we've seen with TKI, is that almost every single patient with clear cell histology has functional loss of VHL. That's sort of the first event in the biology of these tumors. So to some extent, they're all dependent on angiogenic therapy. So that pushes all of this over here. And then there's the rare patient who is so dependent on mTOR, on mTOR activation that they may have a good outcome. Now remember, the mTOR complex 1 actually affects multiple pathways, like you said, right? Survival, metabolism, sequencing of stress signals and so forth. So there's more that everolimus does than just, blocking mTOR itself. But I think just in terms of how uniform the disease is, it's uniform towards loss of VHL and upregulation of VEGF. It's not uniform towards mTOR inhibition to the extent that we can exploit that across the board for most patients. So I'm always asked, is there still a role for everolimus? I think absolutely. For some patients, it's the best drug out there. We just don't have a good way to identify them before. And maybe we will, now we're starting to do circulating free DNA work, and maybe it is that we find something that is more reflective of what's actually going on, in the tumor at that point in time. But as of now, we don't. We've actually looked at the blood. This is an analysis we did off of the same trial. So patients had serum samples collected on the trial, and we started off with over 180 circulating factors in the blood at the time that they started, and we broke it down and came down to 5 factors that were sort of correlated with outcome. And you can see here that we came up with a score of these cytokines in the peripheral blood. And you can see in blue the sunitinib-treated patient, and in red the mTOR inhibitor-treated patients. You can see that we can segregate patients by outcome depending on their cytokine score. But this looks more prognostic than predictive. It doesn't help you to choose between the 2 drugs. It says there are patients who are going to do worse, are going to do better, but you can't choose between the 2 drugs. The question that comes up from what I said before, could it be that if clear cell kidney cancer is so dependent on all this, that non-clear cell kidney cancer is a better setup for looking into genomic biomarkers? So if these depend on other molecular pathways, maybe that's the type of setup where we can help inform our decision making. This is a paper that we had in JCO last month, actually, from a phase 2 clinical trial where we combined an mTOR inhibitor with Avastin, and we looked across different non-clear entities. And some of them responded quite well, and some of them had like 0 benefit from it. And when we did a genomic analysis off of these patients, you could see very clearly the blue patients are the patients that are on treatment for longer than 6 months, and yellow patients are patients that did not benefit from treatment. And you can see here the patients that responded, most of them were either FH mutant in the papillary phenotype or ARID1A mutant. So there is some signals that we're now picking out, and we're actually writing trials now where we're trying to select patients molecularly using sort of these early findings to look into different subtypes of papillary kidney cancer and how we can treat them better. For clear cell, none of that has really panned out so far. Any questions about the biomarkers? Okay. So the last part of the talk is really sort of giving a glimpse of what's going on right now in the first line with immunotherapy. So immunotherapy traditionally has always had a role in first line therapy. This is IL-2 data. So by historic data, this has always been perceived as an immune responsive disease, and that's because of these findings. So this, again, is pooled data from several clinical trials that was published many years ago, only looking at patients who developed an objective response with high-dose IL-2 therapy. And the reason that there's so much excitement amongst IL-2 investigators, still is because there is this tail of the curve that we call it. There are patients who not only achieved a complete response, but they are now 100 months out. So these patients, are many years out from their treatment. Same for some of the partial responders, and likely cured from their disease. And it spurred a lot of interest in the new targeted immunotherapeutics. This is data that was presented at ASCO this year, looking at patients, the very first kidney cancer patients treated on nivolumab. So the phase 1 and phase 2 studies that were conducted in 2009, 2010, 2011, and onwards were pooled in here. So this is about 180 patients in total. And out of those, we're here only looking at patients who have been alive for more than 4 years, which is unusual for metastatic kidney cancer. And that makes up about 1/3 of the patients that went on the trial. So the best data we have about long-term outcome with these new immunotherapeutics is about 1/3 of patients that went on the early trials are alive at 4 years. And out of those, about 1/3 have never needed any other therapy. And you could get the sense that there might be something like a flattening of the curve here also, this being overall survival data. So it's way too early to say, but this is what says, well, maybe we can do similar things to IL-2 with the new immunotherapeutics. Now, PD-1, PD-L1 obviously has been investigated for a long time. There are many other immune checkpoints that are being targeted now with medications. And we know that a lot of the medications we've already had for a long time can modulate immune response and may actually help improve outcome with these agents if paired with them. And there's a long slew of combination trials that are going on right now. We put this together for a review paper only 6 months ago, and since then the list, I think, has doubled. And I'm only going to point out some of the combination data that we have in the phase 3 trials that are actually going on right now, looking in the first line only at combinations. So this is atezolizumab, a PD-L1 inhibitor combined with Avastin, a VEGF-A directed monoclonal antibody. This is the phase 1 study. Only 10 patients with RCC were included in that trial. And you can see here that this cancer stopped to grow for 9 out of 10 patients. And again, they're on these treatments for extended periods of time. This went on to a randomized phase 2. And before the 2 even reported, they went on to do the phase 3 trial. That's how jacked up the company was about their data. So here's the phase 3 trial. And many of these frontline studies are not going to read out for a few years. So everyone's always asking, like, when is this going to change first line? Well, if it does, meaning if they beat sunitinib as a first-line therapy in this randomized trial, it's not going to be until a while from now. This has gotten a lot of press. This was the Checkmate 016 phase 1 study pairing CTLA-4 inhibitor ipilimumab with nivolumab. So 2 very aggressive T-cell activating immunotherapeutics together. And this is interesting. Look, this is probably the biggest phase 1 that's been reported in the immuno-oncology space for kidney cancer. Over 100 patients, and this is heavily pretreated patients, some of these, with an objective response rate of 40% only with immunotherapy. There's no TKI, no nothing in the mix except these immune checkpoint inhibitors. And you see some patients here, and that's always much talked about, who you see as the bar turns red, the patient is no longer on therapy. And some of these patients come off because of toxicity, but their responses are ongoing now here at 96 weeks, so almost 2 years out. And we see these patients that developed toxicities come off treatment, get no other therapies, but their tumors continue to shrink, and that's because the immune system is still at it. So this now is also a phase 3 trial that's completed accrual, and that's going to read out in 2 to 3 years, comparing that combination to sunitinib. Axitinib plus pembrolizumab is another study. Response rate of 55% in the first 11 patients that were treated. And that went to phase 2 and now also in a phase 3 trial that's about to open up. The avelumab axitinib trial. They didn't even do a phase 2. They went straight from phase 1 to phase 3 to catch up with the field. All of these have primary endpoints of OS with the exception of the Javelin trial. So this company is late in the game, so they're not going to wait for OS data. They're going to go straight to PFS and are going to read out a year earlier than others. So you can see here, and then there's another trial. This is a 3-arm trial of another TKI, lenvatinib, that is now being compared in combination with an mTOR inhibitor, with an immunotherapeutic versus the standard of care sunitinib. So you get the sense from the wealth of interest and investment there is for these trials, all in the first-line space, that there's a lot of curiosity how this might change, if it can challenge the current standards. If we summarize what we looked at today, heterogeneous disease, the risk strata that we have, both MSKCC and IMDC, can help us understand better how aggressive a patient's cancer might behave, and it can inform decision-making, especially before a patient goes on to systemic therapy. For systemic therapy, as of now, TKI are the standard of care. There is a lot of interest in finding out more about different sunitinib dosing schedules. The only level 1 evidence we have comparing sunitinib and pazopanib suggests that they're equally effective and that pazopanib might be better tolerable to patients. We don't have biomarkers. We went over that data. And we have a lot of immuno-oncology going on right now in the frontline space. That is all going to take some time to read out. With that, thanks for your kind attention. And we'll take more questions.
So, thank you. That was fantastic. Any questions from anyone? Yes, we were asking maybe as we were going along. Sorry?
No, I agree. I think we asked questions as we went along and had the discussion. It was very good. Yeah, in that time.
So, I don't know how much you can talk about, just a quick question. What's on the forefront here for kidney cancer? You talk a lot about IL and people are doing that, right? I mean, you do a lot of molecular targeted agents in terms of phase 1 studies. So what's coming down the pipeline that you have to study?
Yeah, you mean outside of immuno-oncology, right? So I think one thing that we've learned from the TCGA was a large sequencing effort, right, looking at hundreds of tumors and trying to understand the biology better for clear cell kidney cancer and then papillary and chromophobe. And the one thing that's been apparent for clear cell kidney cancer is that this is a disease that's, other than angiogenesis, very driven by changes in metabolism. So if you take the readout of protein expression, but also on the RNA level and metabolomics, you can see that there's profound changes in how the tumor cells compared to healthy kidney cells process energy. And that's a concept that's actually not been exploited at all so far for targeted therapies, but there are now inhibitors of enzymes that actually work on trafficking of nutrients through the cell membrane. So glutaminase is an enzyme that's very important in kidney cancer. So glutaminase inhibitors are now being used, and there's some single agent data that says that they are effective. There's some responses, and they're now being paired with everolimus, they're being paired with TKI, they're being paired with immuno-oncology. So metabolism is definitely a big theme.
I think we should. So in your practice, do you try marketing?
In my own practice, pazopanib is my first agent of choice. I do, most of my first-line patients end up going on clinical trials, so I use a lot of sunitinib right now, as you can see. I'm a believer in the COMPARES data, so I have used a lot of it. Sunitinib is a great medication. I actually use quite a bit of it for non-clear cell kidney cancers. I use it in specific settings, and I play with the dosing schedules just as anyone else. But for sort of your run-of-the-mill, untreated clear cell kidney cancer, outside of clinical trials, that's my agent of choice. That's what I use.
What proportion of your patients do you observe?
It's a good question. Probably 10%. Yeah, it's a fair amount. The patients have a very active role in making that decision. I have a lot of patients who I've observed for so long now that I'm getting kind of itchy, but they really don't want to. They're asymptomatic and may have, a 2-centimeter pulmonary nodules, and they're not near the, the main bronchus, so I'm not so nervous about obstruction and so forth. But I sort of want to get them started, and they keep coming up with excuses. And if someone is 85 and doesn't want to do it, then I think that's very reasonable. Sometimes I ask them, why are we doing scans? Should we just stop doing scans? But I have many patients with low volume metastases, mostly in the lung, but sometimes pancreas, lymph nodes, definitely bone. We just treat the bone and then we watch them. So these patients that have pathologic fracture and you image them up and down, the only thing they had was that femoral met that was resected and radiated. I watch all these patients.
And so you present some data from the IMDC interview which showed cytoreductive practice.
Right.
And it seemed that the people with the lower IMDC scores seem to benefit more from
Right.
that. How do you conciliate that with this idea of observing people who have favorable characteristics?
I think in some ways it actually goes along the same lines, because it's very difficult to observe someone with an 8-centimeter tumor sitting in their retroperitoneum. But if I take them to, if I send them to the surgeon and they have a cytoreductive nephrectomy and they're left with 5 sub-centimeter pulmonary nodules, I feel very good about observing them. But if they have that 8 centimeter mass in there, and I worry that they're going to start to bleed at some point and so forth, it's sometimes a more difficult concept for patients to follow. To say, oh, what do you mean we're not going to do anything about it? This, big thing inside of me. So.
The population that you observe at Memorial and I guess obviously Tom Manhattan compared to Brooklyn or Voss, are they different?
Well, we have, my patients are from all over the tri-state area, so I see a lot of patients from Long Island, Brooklyn, Bronx, Manhattan. They're different in their attitude, absolutely. So in terms of the discussions I have, a patient from the Upper East Side of Manhattan, that's a different approach from someone who, who's like in the South Bronx or in Queens. So there's difference in how they lead their lives. To say.
How do they end up at Memorial? Because you're a very a cancer hospital, you're not a...
Yeah, oh, you mean how do they enter? Yeah, so we have a big portion of our patients comes in through our surgical program. So a lot of people that had their nephrectomies at some point and ultimately recur are referred to me. I see less and less referrals from outside oncologists. There was, when I started seeing kidney cancer patients, there were a lot of patients that were sent after first line because the community oncologists weren't comfortable making the choice between an mTOR inhibitor and another TKI, and they would come to us. And that, over time, people just got more used to making these decisions, and now we have less of that. We have a lot of people that come to us for clinical trials. They come, specifically for that. And some of them from further away, some of them from right around the corner. Yeah.
Martin, how do you guys radiate your metastasis nowadays? Brent's sitting back there, she didn't ask the question.
Are you using a lot of SBRT? Is that your question?
Yeah. Yes.
Definitely a lot of hypofractionated approaches. The teaching that I've had through the radiation oncologists that I work with is, and that's what I've always heard also, as a resident already I heard, it's not a radiation sensitive disease. So if you decide to radiate, it's better to hyperfractionate and give higher doses. Where we probably use most radiotherapy is for osseous metastatic disease. So bone metastases really respond quite well in terms of symptom control to XRT. CNS metastases, obviously. And then I have patients who have symptomatic endobronchial disease, so pulmonary metastases that infiltrate into the thrombus, but also mets that start endobronchially. And oftentimes they see the interventional pulmonologist first, and they have laser resections or stents and so forth. But when all fails, radiation to those, I don't know what your experience has been, can be extremely effective. I've had patients who have been treated again and again with resections or laser this and laser that, and every month and a half things come back. And then if you radiate them focally, oftentimes they have disease control for many months afterwards.
Did that deal with like an SRS or SBRT?
Yeah. Yeah, one question that came up, I don't know, was it no, that was the residence round we did yesterday. So brachytherapy, that was a patient that was treated in Victoria. There was someone who had endobronchial brachytherapy. I'd never seen that before. That was fascinating. But that patient apparently did quite well with it. Yeah.
Wow. So you guys have stereotactic radiotherapy right in Memorial then?
We do, yeah.
And how often is that used for your brain mets?
That's the standard for brain mets. It's rare for us to not use SRS for them. We use whole brain XRT if they have multiple lesions, but if a patient has 3, 4, 5 lesions, often they're all treated individually with SRS.
I was going to say, we have that available in Calgary, our sister center down south, so that those patients with at least 1 to 3 brain mets, sometimes after whole brain RT would get referred for SRS to the brain. We're starting to jump on the bandwagon of SBRT for especially bone mets, oligometastatic disease. We have a trial open at the Cross Cancer where we're trying to accrue patients to that. We're definitely not as aggressive as some of our colleagues in Eastern Canada with respect to our use of SBRT because our group doesn't fully embrace the long-term data yet, but we have the technology and we're just picking up slowly.
It's coming. And do you guys have what do you use for targeted therapy for oligometastatic disease?
A surgeon.
Always a surgeon? Like, some of them aren't always resectable.
Yeah, no, I mean, so oligometastatic disease that's unresectable, where I feel the patient has to start and can't be watched, I put them on, depending on where they are, usually they go on TKI. But they're usually eligible for trials also. There's no reason to treat that patient differently than the next patient. Many patients with oligometastatic disease that can't have localized treatment, be it surgery or radiation, I watch for a little bit if they're asymptomatic from it. But ultimately, I treat them the way I would treat someone with disseminated disease.
You guys have a cryotherapy for the oligometastatic disease that
Yep.
you can't resect?
Yep. So, we try quite a bit of that, but my own experience has been that surgical resection, just has a higher likelihood of local control. I have some patients who did extremely well with ablation approaches, but I have many where we try, and the morbidity is low, so the patients don't mind it, quote unquote, but oftentimes the disease then, regrows in that area. Now we're doing a lot of, we're trying a lot of this and that where we combine local approaches with immuno-oncology. So we try to see if ablation plus checkpoint inhibitor therapy might actually augment, a systemic effect. But that's very, very early data, so no one really knows if that applies or not.
Yeah, this is just pure speculation, and it's
Yeah.
outside the topic that you spoke about, but we've seen some negative TKI adjuvant trials.
Mm-hmm.
Now we're getting very enthusiastic about IO.
Yeah.
Any sense from your perspective,
Yeah.
when you think this is
Yeah.
going to be the real deal?
Right. So the negative data, right, is the ASSURE trial that was reported by Naomi Haas in Lancet earlier this year. And now, as I'm sure you've all heard, there was a press release by Pfizer that the STRAC trial was actually a positive study, meaning there was a recurrence-free survival benefit to sunitinib over placebo in a very, very similar trial, which probably, that difference, one trial being negative, the other being positive, must be something about how they selected the patients, but we're not going to find out until ESMO. So we only know it's a positive trial. The background to this is actually, it's very interesting. I only learned about this recently. I've always wondered, why do companies do this, these press releases? But it's actually the law in the United States. So if a trial reads out within 48 hours, pharmaceutical companies have to report the data to prevent inside trading. So that's why we know about this. So we found out about the STRAC trial being positive. We know nothing else. Okay, so we're going to find out in November why it's positive, how positive it is, and if there really is a role for TKI in the adjuvant setting. Now, your question is immuno-oncology. Yeah, so I do think so, because I just wrote a trial to do it. Otherwise, I would have wasted a whole year of work. There's one large trial that's going to go through the cooperative group trials that Lauren Harshman from Boston is leading, which is a trial that looks at neoadjuvant plus adjuvant nivolumab in patients with non-metastatic disease. So randomized to either go straight to surgery or have nivo, the surgery, and then a little bit more nivo afterwards. And we'll see what happens. The reason that I think that approach is valid is because PD-1, PD-L1 biology is very much about tumor infiltrating lymphocytes. So it's about T cells that have already been epitope directed but are dormant because they're shut down by PD-1, meaning they're already in the tumor. So to me, the best possible scenario to explore that avenue is a preoperative approach where you try to elicit a systemic immune effect for any rogue metastatic cells that might be sort of chirping about somewhere before you take out the primary tumor. And the other thing that these trials are is a great opportunity to look into biomarkers because you get so much tissue. It's like a bladder cancer trial, Yeah.
I think that is a trial that is probably coming to
great.
Canada. I think we're waiting to hear. I think they're just sorting out some details. The one thing that's been said though about that study is that people need a biopsy up front.
Yep.
I mean, I don't know if I would say it's a big issue, but I think there's some people that say,
Yeah.
well, why do you need to, you're doing another procedure,
Yeah.
it's invasive, it's
So-
tissue beforehand, but
Yeah.
I don't know. I think
So
the
my
safety of biopsy
experience with that is, the trial that I wrote that we opened a few months ago is a baby version of that. We're doing the exact same thing, but we're only doing it's a biomarker trial, so we're looking at many, fewer patients. And everyone has to have a biopsy done, and it's not a big issue. And that's also my experience from working in the phase 1 group, where there are many trials that you have to have biopsies before. If you have something that is a good match for your patient, the patients are going to want to be on the trial, and they're actually going to mind the biopsy much less than anyone anticipates beforehand. So when we opened this pre-op Nivo trial, we also thought, this is going to be tricky to talk patients into, but every single patient I've talked to about this, they're like, yeah, biopsies, can we just talk about the trial? Because think about it, right now, for someone who's high risk, non-metastatic disease, and some of the nomograms will tell them that your risk of recurrence is 70%, we tell them we do nothing. So they come to us and they say, what are you going to do for this? And we say, well, we're going to watch you with CAT scans every couple of months. And they say to us, okay, you're crazy, and I want you to do something about this. So if it's one biopsy that they need to go on a trial where you actually, are more proactive about it, I think they're going to do it.
Sessions that we're also calling patients are fine with it. It's making sure that the med-oncs and the urologist coordinate so that we
Yeah.
don't get the patients post-fracture.
Yeah.
So you have a chance to do the tissue procurement.
Yeah.
It's coming.
Yes.
These guys do targeted therapy.
We will say.
Big target.
They got their scalpel.
With the co-stimulatory pathways in that, I mean, a lot of the data basically says that the expression of PD-1 and PD-1 ligand don't correlate with response to seeing the tissue.
They correlate, but they're not perfect biomarkers. So we have data from large cohorts for nivolumab, and we have data for some, less patients. But now in bladder cancer, it's the same story. In melanoma, was the same story. So what we see is, if you look at PD-L1 expression, be it looking at it in the tumor cell, in the immune cell, or at both together, then the higher the expression of the target, the higher the likelihood that you're going to have a favorable response. But if you have no expression or a limited expression, you can still have a great response. So there's correlation. It's predictive to some extent, but it's not a good biomarker because you would exclude patients from the treatment who may go on to develop, a CR. So there are patients that were on these trials, especially in the bladder cancer world, who had CRs, and on their pre-treatment biopsies, they had 0 PD-L1 expression. So that means the biomarker is not going to be helpful because that patient really needed to go on that treatment. But the more expression was seen, the higher the likelihood of finding these patients. Meaning if you look at the extreme expressors, their response rates are much higher than the patients that have lower response. For the individual patient, that doesn't matter. Either you respond or you don't. But for a biomarker, ideally you want something like ALK rearrangements in lung cancer. If you don't have it, you're going to have nothing from crizotinib. But if you have it, you're going to have a high response rate. So that is what PD-L1 is not. So it doesn't help that way.
So I think we need to let Martin have something to eat. Thank you so much.
Yeah.
Thank you, everyone.
Okay. Feel free to find